Perfect. So I am excited to welcome everyone to day 4 of our open virtual summit, where today we're going to focus on building bridges between pharmacists, pharmacy teams, and public health. And I'm excited to welcome you here on behalf of Open and the Center for Practice Excellence. My name is Lisa McCarthy, and I am a clinician scientist and pharmacist with the University of Toronto and Trillium Health Partners in Peel Region. And my co-host for today is ANNALISE Mathers, who is a research officer and all things open extraordinaire CPE, who really runs the show on these summits. So excited to work with ANNALISE today and our speakers to bring you an exciting program. So next slide. To get things started in terms of acknowledgement, I'm joining you today on behalf of the University of Toronto, which is located on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And that this land, and I want to acknowledge that this land continues to be the home to diverse First Nations, Inuit, and Métis people. I recognize that others are joining us today from across different territories, and I invite you to provide your own acknowledgement of the ancestry of the land and the commitments made to these peoples. That's great. So thank you again for joining us here. I'm excited to welcome you on behalf of 2 organizations. So I'm an executive member of Open, and Open is the Ontario Pharmacy Evidence Network. We are a multidisciplinary team of researchers who partner together to evaluate the quality, outcomes, and value of medication management services that pharmacists and other healthcare providers provide. We are fostering knowledge translation and exchange, building capacity in medication management research, and addressing the needs of Ontario's vulnerable populations. So that's what Open is all about. And next, we'll tell you a little bit about CPE. So the Center for Practice Excellence at the Leslie Dan Faculty of Pharmacy generates and uses leading edge medication management research and innovation to drive educational programs, practice, and revolutionize patient care. So CPE is similarly missioned with Open in that we're all working to try and bring together practitioners, researchers, staff, students, pharmacy teams, professionals from around the world to serve as a network to access expert advice and research. So excited to co-host with these 2 organizations. And as I mentioned earlier, this is day 4, hard to believe, of our virtual summit series that has been going on since early days in March, which feels like a different time in the world. But today we're focused excitingly on building bridges between pharmacists, pharmacy teams, and public health. And next slide. Oh, housekeeping, got to do that. So please note that this event will be audio and video recorded, and all recordings will be available on our website shortly after the event. We'll be moderating the Q&A period using the chat box feature in Zoom. So please use that chat box to type in any of your questions or constructive feedback that you have for our presenters. A little bit more housekeeping to do, I believe. Right, so the aim of this summit is to disseminate and share knowledge that's generated through research. And so we would ask that all participants recognize that some of the research being presented today is still in progress. And in light of that, we are appreciative of the generosity of our speakers who are sharing in progress work with us, but we'd like to ask that participants refrain from sharing specific results and data, including through social media, for that purpose. So thank you very much for respecting that. Onwards, we're going to get started today. So before ANNALISE officially welcomes Kelly GRINDROD, I would like to say a personal hi to Kelly, who I haven't had a chance to see in quite a long time, and to congratulate her on her award this past weekend, recognizing her exceptional achievements in academia and research from the Ontario Pharmacists Association. So excited for ANNALISE to officially welcome Kelly, but wanted to say a personal hello. And yes, I see some applause in the chat, so applause for Kelly on her award.
That's great. Thanks so much, Lisa, for getting us started today. And also congratulations to Kelly. We're really delighted to have you here today to provide the keynote address to kind of get our event started. I've just made you a co-host, so I will stop sharing my screen and allow you to get your slides up on the screen whenever you're ready. While I'm doing that, I'll just provide a quick introduction for you. So Kelly is an associate professor at the University of Waterloo's School of Pharmacy. She's also the founder of Pharmacy 5 and 5. She completed her pharmacy degree at the University of Alberta and a hospital residency at the London Health Sciences Centre. She also has a PharmD Master of Science degree and a postdoctoral fellowship at the University of British Columbia. She's been at the University of Waterloo since 2011, and we are absolutely delighted to have you here today, Kelly. Thank you. I'll let you take it from here.
There we go. Had to unmute myself. Okay, so thank you so much for having me. I'm going to talk today about what I kind of understood and come to know in this last year about building bridges between pharmacists and public health. But I know that there's some of you who are very much doing this work as well. I see Brad is here and Shelita, and I know that there's others as well. I'd encourage you to share some of your perspectives in the chat as I'm talking, especially if you have things to add to what I'm saying, or even during a Q&A, you might want to be sharing some of your perspectives. Okay, so we've done the land acknowledgement, for where I'm situated. I'm on the traditional territory of the neutral Anishinaabe and Haudenosaunee peoples. And one of the things that I really liked at our university is that when we have a new president, and whenever he does the land acknowledgement, one of the things he makes a point of saying is, it's not only a matter of acknowledging the land that we're on, but also the reminder with each session that we should be doing learning with each of these acknowledgements, and reminding us and keeping us motivated to understand what's happening with this. So with that, I'll encourage you to do the same. Conflict of interest statement. So I have funding from the Public Health Agency of Canada, NSERC Promo Science to promote vaccine confidence, and the British Academy, which is a publicly funded group in the UK. I'll get to that in a minute. I also have speakers fees from Shoppers Drug Mart, Ontario College of Family Physicians, Ontario Pharmacy Association, or Pharmacists Association, I should have written, on the Ontario Medical Association. So I'm going to really focus on three things that I think pharmacists have particular value in when it comes to public health. The first I'm going to focus on is vaccine planning and delivery. The second is on information translation and communication for the public, but also other healthcare providers. And the last is influencing policy. And the third one is really where I'm going to focus on the research that we've done, a project we've done funded through the British Academy in collaboration with a team from the UK. So if we start with vaccine planning and delivery, as we've just learned through this pandemic, there's a long, bumpy road. When you're at the start of it, you don't know where you're going. You can't see the future. You expect it's going to be bumpy, and it is so many ups and downs, and eventually over the hill, twists and turns. So some of the things that you think you'll know when this starts, but it's hard to figure out is, who's going to vaccinate? How are you going to track the vaccines? Where are they going to be offered? How are you going to manage scarcity? How are you going to manage complex cold chains? How are you going to manage rolling eligibility? So you might think rolling eligibility is a good idea before you start, but when the rubber hits the road, it's a whole nother experience. So how's that going to happen, practically speaking? When do you activate primary care? Do they want to be activated? When do you activate pharmacies? Do they want to be activated? And then even in pharmacies, as we saw in Ontario, it was not just activating pharmacists, but also technicians, or bringing nurses into pharmacies and whatnot. And then what do you do with the records of the vaccines? Do you use them as passports? Do you use them for mandates, et cetera? So these were a lot of the questions that we were faced with at the beginning of the pandemic's vaccine rollout, when it was clear we had vaccines, but we didn't quite know how it was going to go. Now, one of the other parts of this is that we really became very familiar with who was at the table in vaccine policy. Now, these are groups that are typically at the table, have historically been at the table, but it became very visible in the pandemic. Nowadays, even general members of the public could probably explain a lot of this to us. So you've got the government of Canada who's procuring vaccines. They have to source vaccines and might be providing research on vaccinations, and they're responsible for distributing, at least in the pandemic, to the provinces. You've got Health Canada, who is tasked with weighing the efficacy and safety data and determining what the approval will be. You've got the Public Health Agency of Canada, who is responsible for communicating to the public, but also tracking safety in real world situations. You've got the National Advisory Committee on Immunization, or NACI, who is tasked with making the guidance or releasing the guidance on how to use the vaccines. In the pandemic, we saw them do that in lockstep with Health Canada. So when Health Canada's approval would come out, NACI's statement would come out. And then you've got the provincial governments who are responsible for getting the vaccines to actual people, so into the regions, et cetera. but also eligibility criteria that was informed by the National Advisory Committee on Immunization. And then you have the other groups, and it's always a little bit uncertain where they fit. So you've got hospitals, you've got local and, in Ontario, provincial public health, you've got pharmacies, you've got primary care, and they're kind of interspersed throughout this. But those top 5 ones are really kind of the main, most visible influencers based on kind of how policy had been made historically, and then things have shifted a little bit. So in the course of our research, I came across something called the punctuated equilibrium theory. And there's a great link there for those of you who do happen to work in healthcare policy that's worth a look at. Basically, what it says is that policy over time is fairly stable, right? It slowly changes, subtly changes, it's tweaked, et cetera. And you've got one group, you actually might end up having almost like a policy monopoly group, who is responsible for making and adjusting and tweaking and changing the policy. But not only who is making the policy, but the policies themselves is relatively stable over time. This can go on decades, it can be relatively stable. And then some big change happens. In our case, it was a pandemic. It could be a change in technology or something like that, but really, it's a big event. And it really upsets the whole thing. And what you see is policy changes rapidly. And the system's not set up for rapid policy change, right? It's set up for slow, gradual decades evolution, not 1 year, everything changes. And so you see there becomes a real tension where you have the policy monopolies accustomed to controlling the policy and changing slowly. And now new players who are coming in and influencing policy, changing policy, giving feedback on top policy, more visible, maybe they didn't even exist before. Once you go through that critical event and come out the other side, you resume that slow, steady, and your policy monopoly now might actually be a new group that is the monopoly. And this might continue on until the next critical event and it happens again. So for me, this was very descriptive of what we just lived through. So as this was all happening, one of the things that had happened in our region was I was invited to create a vaccine, the pharmacy working group for the Region of Waterloo Vaccine Task Force. And to give you some perspective on how this came about, early on when things were starting to evolve, we knew we had vaccines, policies were starting to come out. There were pharmacy groups kind of on the table. So in Ontario, the Ontario College of Pharmacists had helped to facilitate, the registrar had helped to facilitate semi-regular phone calls with a lot of the stakeholders who could come in and kind of give their feedback, ask their questions, kind of nudge, I'm not sure if this is happening or whatnot. There was an attempt to get the players at the table, but it was challenging. There was still a real separation where the provincial task force was focused on the logistics of getting it out, a bit on eligibility, but then the actual on the ground people were trying to figure out what this was going to look like. In each region, once the vaccines were going to the regions, you ended up with these regional vaccine task forces. And in our region, it was very structured, and they used it was a military approach actually, and where it's very organized, who's at the top, and you have multiple working groups on this task force. Some are tasked with organizing it, organizational groups, communication groups, engagement groups, primary care groups, public health, etc. One thing that was missing was a pharmacy group. So they called me and they said, as a pharmacy faculty member, would you be willing to set up a pharmacy working group? So I said, sure. And interestingly for us, our operational lead was the director of pharmacy at the local hospitals. And she's a former retail pharmacist, Vicki Murray, she's fantastic. She had been really focusing on the logistics because these vaccines largely came in through hospitals. And so it was the hospital pharmacists who did a lot of early leadership on this. So we said, okay, well, let's take Vicki, who's at a lot of the ministry calls. She's at the executive calls in our region with the medical officer of health, all those people. Let's start with her. And then we invited every regional manager for every major chain in our region. We invited representatives from each banner. We invited a few pharmacists from the independents. We met weekly online at 8 a.m. before the stores opened. We had some faculty members there as well. We shared meeting information at our province-wide calls. So we'd have a conversation at 8 to 9. Then often someone like Vicki or myself would be on a phone call with the Ministry of Health. And we were actually able to say, well, in our pharmacy working group meeting this morning, this is what we were told. And one thing that was very interesting from this perspective is our local public health loved what came from the pharmacy group working group. They loved it. They actually took our working group members and put them on other committees. So on the mobile team committees going to long-term care and the mass vaccine committees, it set off working out how to hire pharmacists into public health. How do you pay them? How do you credential them? All of that kind of stuff. That was great. But what was really interesting is what we saw at the ministry calls, the province-wide calls, where you had public health units, you had policy makers in the ministry, the bureaucrats. They would often not hear from the pharmacy perspective, or that was actually happening in a different part of the ministry. And so what they would bring was complaints about pharmacy. Oh, pharmacists are having problems with their fridges. Pharmacists are not following the rules. Pharmacists are not doing these things. And when we'd come to these calls and say, hey, this is what's happening in pharmacies right now, it slowly started to shift where they actually started to understand. Now, pharmacy wasn't just a group they sent vaccines to and then, things went wrong. It was a group that was having real experiences on the ground and really valuable information they could feed back. And what started shifting was the ministry, public health would come to a call and say, in one region, they would say, oh, this is happening with our pharmacies. And the ministry would say, have you started a pharmacy working group yet? This makes a huge difference. Medical officers of health started reaching out to me in other regions and saying, can you recommend a pharmacist in my region to be on a pharmacy working group? We also heard from those regional managers at the chains where they often managed pharmacies in our region, but also neighboring regions or all of Southern Ontario or all of Ontario. And they started to really look forward to the meetings, because they would hear what the ministry was thinking for the first time at our meetings and then could take it back to their employers and their chains and then distribute it to other regions. So you saw that, for us, it was really critical to have pharmacists kind of work together to identify the challenges and then have pathways to communicate it to the people influencing the policy that we had to carry out. I also had done a weekly newsletter through MailChimp because the communication was so ever evolving, but I'll get to that later. So the next thing to consider then, so there's a pharmacist role in just logistical planning, influencing policy, all of that kind of stuff. But another role that we really saw for pharmacists in the pandemic was their role on translating information and communicating it, public health information, not only to the public, but to other healthcare workers. So to nurses, public health nurses, to primary care physicians who might be vaccinating, for example. There was a real need for pharmacists to educate, translate, communicate. So in June of, I would say early on, but it's not really early on, June of last year, Dr. Kate Miller, who is a family physician, a rural emerge doc, and also a member of the Ontario Science Table, had posted this tweet asking for if anyone knows of a good patient decision aid on mRNA versus repeat AstraZeneca for second doses. If not, do you want to collaborate on one? And a group of us responded, all of these people responded. And what you see here is, so there's Kate who started it. Dr. Pai is a hematologist at McMaster, but also leads the treatment recommendation group at the Ontario Science Table with Dr. Andrew Morris. Dr. Chittle is a family doctor, public health provider, does a lot of public health type outreach, doing her MPH at UWaterloo. Kristen Watt is a rural community pharmacy owner. She's Ontario's Pharmacist of the Year, had done thousands of vaccine doses. Sabina Vora-Miller is a science communicator under the handle Unambiguous Science and also the lead of the Vora-Miller Foundation. Samantha Yamin is a science communicator. She's a neuroscience PhD who has long communicated science, but really got involved in the pandemic. Her site is Hey Science Sam. Dr. Noah Ivers and Tara Kieran are family physicians at U of T, and together Noah represents Moore Center for Effective Practice, and Tara works a lot with the Ontario College of Family Physicians. Dr. SAMEERA Jamie is an immunologist at Western University, and she was doing a lot of the vaccines when people wanted exemptions, when the mandates came in, when people had allergic reactions, when people felt they had contraindications. She was doing a lot with the vaccine. Plus, her expertise, she has a PhD in immunology as well as being a physician immunologist. So she was translating a lot of the immunology knowledge for people. Dr. Holly Whitteman is a human factors engineer and an expert in shared decision-making at U Laval. Her expertise is on how do you present numbers? How do you present information so people can make decisions? And then there's myself and my team, which is Adrienne Poons, our graphic designer, and Rosemary Colleen is the University of Waterloo's medical director of continuing professional development. But she also does all the medical editing for Pharmacy 5 and 5. So we got together, and it was a really interesting experience because you can see there's a couple of pharmacists on there, and we created these 3 tools in a weekend. Now there's multiple iterations. So there's the graphic, there's a 1-pager, there's a 2-pager, there's a 6-pager. And what we learned through the process of doing these is that we could create these documents, interdisciplinary, multiple experts, physicians, specialists, community, pharmacists, engineer, graphic designer, editor. And we did this all through Twitter group direct message chats using Google Documents. We had our initial graphic design, and then we rapidly sent these early iterations out on Qualtrics surveys. We actually got a rapid ethics approval after this initial one to get feedback on errors, omissions, what was unclear, to build trust. And we were able to actually, those first ones, release them in over a weekend, get this information out. And it started a process for us of interdisciplinary collaboration, with pharmacists being a real key in translating complicated information, like what might come from Public Health Ontario, which does fantastic work, Ontario Science Table, to frontline pharmacists, family doctors. We also learned along the way too that the surveys, when we conducted them, would reach predominantly white middle-class people, like higher levels of education, higher levels of income. And we done that by including demographic questions, but we realized we needed to be more targeted to reach other groups. So we also started using things like focus groups with our region's outreach communication teams, getting community member feedback through a relationship and trust building group that we'd established with public health that has many members of the Black community, for example, and making sure that we get their feedback often first, and then running what we develop with them through the surveys for the more general, broader feedback. And again, we would share these final images through partners. So the first one that we did, we saw actually get picked up a fair bit. And so, in papers, for example, would share the image. We were able to publish one of them in A Healthy Debate. You can see to an op-ed with Dr. Edwards, David Edwards, and Heather McDougall, a health historian, we had written around the time we were doing this, trying to put AstraZeneca into context. And that this was actually largely driven by Dr. Edwards. But you could see that there are opportunities here for us as pharmacists, but also interdisciplinary teams to talk to the public directly. We kept going with this, and we made, a myocarditis document. We had all sorts of different information. A big undertaking was ones for the kids 5 to 11. And we followed this process and we conducted a survey. And in this one, we had over 2,000 responses, around 2/3 of which were likely from anti-vaccine communities. And they were fantastic responses, because what they actually did was often picked up on words that are polarizing words that set people off, like those red flag words that to the anti-vaccine community immediately leads to distrust of a document. And it helped us go through and try and pick things that were more neutral, less emotional. We have members in our team who are very pro-vaccine, and that can come through. So sometimes those surveys helped us back some of those things up a little bit, so it's a little bit more neutral. The document on the bottom, the why now is the right time to vaccinate, the original one was called Now or Wait, and we released it when the National Advisory Committee on Immunization first approved the 5 to 11 vaccines, because they gave a fairly soft recommendation that it could be offered, but the risk in children was believed to be relatively low in terms of the virus, and we didn't know what to expect with safety like myocarditis. So at first they said, the US is doing a lot of this. We're going to wait and see how the data evolves. Right now, we'll say, sure, you can get it if you want. And in the new year, we'll have a stronger recommendation if things go well that you should vaccinate. And so one of the things that we did in the Now or Wait, when we put it together, we actually, as we released it, the Chief Medical Officer of Health in a session with primary care providers actually specifically recommended our document to healthcare providers to use in talking with families and educating themselves. So we actually saw these things get picked up in ways we didn't quite expect. What you see here is the one that we updated when the National Advisory Committee updated their recommendation. We then also, and through our connections that we built through this, we're able to get a heads up on that so that we could release roughly around the time this was happening. We were asked by the Black community members specifically, and these are diverse communities, right? There's African, Caribbean, there's a hugely diverse community, but our community members fairly universally said fertility is the main concern. So what they wanted was a document saying whether or not the COVID vaccine would impact female fertility. And what we actually found in the literature review and whatnot is no, the vaccine doesn't, as other vaccines don't, or male fertility. No one asked, but also not male fertility. But what it did do, the infection could impact male fertility. And this was something that was not asked. And this was a tension point. They would almost say, we didn't ask about the boys, we asked about the girls. So we did a survey and we got great feedback, but we also found we had to do focus groups because, what we identified was a tension between, say, gender inclusive language, where we talked about, people who have a uterus versus fertility in girls. And we found when we worked with one community, for example, they felt very strongly it should be gender neutral. And another community felt very strongly it should not be gender neutral, it should be gender specific. And so we actually realized you needed to have adaptable infographics that, different communities get different infographics. And so this was an important lesson learned here. And we've continued on with booster doses, and the booster policy is so complicated, a lot of work to try and clarify that. Paxlovid has emerged with just as much confusion. And a lot of this also led us to work with the Ontario Science Table, releasing guidance documents on prescribing fluvoxamine, on Paxlovid, and even our most recent one on prescribing Paxlovid when someone takes a DOAC. But what you don't see here is actually the main authors behind these documents are pharmacists, large teams of pharmacists. There were, like Alice saying, it was the real lead behind this at Sunnybrook, HIV pharmacist for years, amazing. Lots of pharmacists, specialists in cardiology and hematology, in nephrology, pharmacists working at assessment centers prescribing Paxlovid or whatnot, drug information pharmacists, pharmacists with expertise in drug interactions. Really, when we worked with the physicians on these teams, they've come back to us after and just said, wow, we knew pharmacists were great, but wow, you guys have exceeded our expectations. So that's the second one. Like I said, that was about the role of pharmacists in communicating. But now let's shift to the study we did with a British team funded by the British Academy. Now, this was a policy analysis of Canadian vaccine policy compared to the UK. And this is a 100-page document. I think it's fantastic. It should be out very shortly on the British Academy website this week or next. But I'm just going to give you some snippets of it. So this was an effort between a team of researchers here, so led by Dr. Waite and myself, our postdoc, Dr. Tatui, Liz Vernon-Wilson's on the call. She was one of our lead researchers doing a lot of the interviewing. Bara Abdallah Al-Sherman is a PhD student who worked on it. Ginny Wong is a pharmacy student or co-op student. And in the University of Lincoln in the UK, this was led by Dr. Agnes Nanyonjo, and then a team that's very similar to ours there. Now, we were looking at policy. So Canadian vaccine policy is national, but it's really provincial. It's like 13 different provinces. The UK has, England, Wales, Scotland, Northern Ireland. So we were really looking at England. And then we were looking at kind of a group like kind of Southwestern Ontario compared to this region called East Midlands. So generally looking at like provincial and English policy, but then also we did interviews that got all the way down to like Waterloo region compared to East Midlands. And we did two things here. We did a desk review of the vaccination policies that were released between March 2020 and December 2021. We were looking at policy processes, content, and actors. This is called a policy triangle framework analysis. Then we did a policy framing analysis. So that's called a framing analysis for convergence and divergence between England and Ontario. And we also conducted qualitative interviews in both England and Ontario to understand how the policies were communicated to the public, the societal response to the vaccine policies and messaging, and the community level interventions that were used to build vaccine confidence in various communities. So as we went through this, there's a whole lot to this report, but one of the things we did was have case studies. And one of the examples was the AstraZeneca case study. We wanted to see how they compared Canada versus the UK. So Canada didn't make vaccines, but the UK made AstraZeneca, right? We had we had shut down our vaccine manufacturing capacity. We had to rely on others, but they had their own homegrown one. So the WHO and the EMA approved AstraZeneca in January, and Canada wasn't approving it for another month yet. When Health Canada finally did approve it, they limited approval to less than 65 based on the lack of efficacy data. The UK didn't do that. They accumulated real-world data that was released right around this time, and Canada very quickly then approved it for over 65. So that was one of the first, like, the policy came out and then it was rapidly changed. Very quickly, and that was a concern about efficacy. Very quickly, the blood clot concerns led to temporary holds in much of Europe and Canada. The UK generally stayed pretty consistent, though. The advisory groups estimated it was 1 in a million, and then at 8 in a million, people got more nervous, and then 37 in a million. And ultimately in Canada, they halted the use, but they didn't do that in the UK. So Canada approached it by praising people and saying, hey, you did the right thing for taking AstraZeneca to protect yourself and your family, but now we're going to recommend you do mixed vaccine schedules. The UK didn't take that approach. The UK said risk versus benefit, vaccine scarcity, let's stay the course. So Health Canada, the UK kind of used a constant framing of risk versus benefit. They were very consistent, but in Canada and Ontario, Health Canada and NACI actually shifted from framing with concerns about efficacy, not over 65, no data, that was efficacy framing, to safety, dangerous, we're not sure. And actually those competing frames added a lot of complexity and uncertainty, whereas the UK focused on constant, consistent reassurance. So, we can argue whether one was the better approach than the other, but one of the things that was apparent is whereas the UK's approach did reassure the public, the Canadian approach did not reassure the public and actually triggered a lot of vaccine hesitancy and concerns and anger. And we still deal with that today, almost a year later or over a year later. So when we looked at these policies, and there's many like them, the mixed vaccine, the delayed intervals, we went a different way. Like, we very strongly, consistently vaccinated teens, but the UK didn't. That's where their controversy happened, which was interesting. So very frequent policy changes that were complicated, leading to confusion, frustration with policymakers, mistrust. A lot of this caused concern about competency of healthcare systems. There was fear and anxiety. And I'm going to leave you with a few quotes and then I'll skip through to the end. So for example, one of the people, vaccine clinic lead, had said to the Indigenous population and community, it was difficult because it felt like we were breaking their trust. We're giving it at 21 days, and then later we found out it's actually more beneficial if it's longer. Making sure that people understood that the science is always changing, recognizing it can change, but we're not changing it to deceive you or to break your trust. We look like we don't know what we're doing, said a community pharmacist, whether that's between the policies being too complicated or not communicated with enough time or not flowing the way they're intended to flow. So I'll skip through these because we won't necessarily have time. But what I want to point out here is one of the big findings we had from this research when we looked at these case studies, we talked to people, we looked at just how much policy changed in Canada compared to other places. We actually found that, we talked in Canada a lot about having equitable policy. We aim to prioritize Indigenous communities first. We also aim to prioritize hard-hit, marginalized, racialized communities by targeting postal codes, for example. But one of the things that we did is we constantly changed our policies to meet these things. We constantly strove to have perfect policy. And each time we made those changes, it actually made it very hard to reach marginalized groups. So for example, when you first set out an eligibility criteria and it gets translated into 10 languages, then you can reach those communities. But if it changes the next week, you have to retranslate. So you do. it reaches the communities. You change again, and you're going through community leaders, but this time you think, well, I'm not going to translate again. It's just going to change again. So you wait. You don't translate. Gaps start to emerge. Translators became in short supply. The quality of translation went down. Community leaders started to question what the heck was going on, and they disengaged. It was hard to reach communities. When they came in, people were upset. And actually, people filled their own gaps. So if they came from another country and spoke another language, they would seek information in their own language from their own country. And that country may have different vaccines. It may have misinformation circulating mostly on things like, say, WhatsApp or social media in different languages. So we actually, by making policy so hard to enact on the ground, we aim to have perfect policy, but we actually really made it difficult for on the ground outreach, frontline pharmacists, frontline physicians, frontline public health, community leaders, outreach efforts. It was at the expense of all of those things. And so we actually saw that equitable policy probably wasn't all that equitable at the end. So one of the community leaders said to us, it's not what is said, but who says it. So marginalized communities need to hear about vaccine policies from their community leaders and trusted sources. Governments need to invest in building that trust rather than doing it on a reactionary basis after the fact. So all policies need a clear justification, communication strategy, and community engagement to be effective. Trust building takes time. Efforts to refine policy can erode trust. So I'll leave you with my conclusions here. Pharmacists have frontline knowledge that's missing from policy making tables. I'm so glad for those of you who are in the talk, who are sitting at these tables now, you bring enormous value. Local public health is actually also missing from those tables. Public health actually wants to partner with pharmacy. We're partners. We don't work under public health. We work with public health. And the pandemic has really given that to us as a gift. Pharmacists are experts and are seen as such, especially as we come out of the pandemic. In many regions, public health didn't realize they could work with pharmacy. Public health has often only worked with pharmacies when things go wrong, like I say, temperature excursions with the fridge, not side by side in a vaccine clinic. So this has been a big shift. There's an opportunity here for pharmacy to play a role in other public health services and bring these exact same lessons, these exact same messages around equity and whatnot to other areas as well. So I'll leave it there. Thank you very much.
Thank you so much, Kelly. I feel like you could have gone on and we'd still all be absolutely captivated. Particularly really appreciate kind of your comments around building trust, and that takes time, but it can also be very, very quickly eroded with some of these aspects of miscommunication or waiting to communicate. So I really appreciate your remarks on that. I'd like to open it up for question and answer. If you can just type in any questions you have for Kelly in the chat box, I'll convey those. Maybe just while people are typing or getting some thoughts together, I think Shelley online has similar sentiments that I hopefully just expressed. She says, this is the single best example of pharmacists directed nimble knowledge mobilization through this pandemic that I have seen. Have used it in practice, presentations, and policy discussions. Kudos to your leadership. That's wonderful. You're just on mute, Kelly.
Sorry, Shelley was at those tables as well. And, I found it really interesting. Her and I would connect sometimes as we're kind of in these spaces. We've been peripheral to them at some point, but, really trying to influence policy. A lot of things that were unclear became clear. And I know Shelley shared really was such a valuable pharmacist to be at many of those decision tables. So hats off to you, Shelley, for all you've done as well. Suzanne, so I'm curious if you have any thoughts around the issue regarding pharmacy being a heavily corporatized profession, and whether that was viewed as an enabler or a deterrent regarding scaling public health initiatives. This is a great question, Suzanne. So yeah, I think this was probably a bit of both. And so I think what we saw was a lot of lobbying by, for example, the chains or a select group of chains to have pharmacists more at the table. And that may have helped pharmacy in general in terms of getting things off the ground. I think at times it helped, at times it hurt. And that was really often more of a, the corporate trying to get services and profit. But I think also this is a place where pharmacists should be, and it should be visible. One challenge that we have had, though, and I see this with public health, is that public health does still tend to think of us as those chains and those corporations. Now, we've had in our region, this has sometimes been for the better. I'm going to just call out a couple of our pharmacies in our region. We have a couple of Walmart pharmacies that have just been extraordinary. And like the public health will say, Walmart. And I think that was funny because it really called into question, what did you think Walmart would like? Yes, there are great pharmacists who have always been in Walmart. Walmart does amazing things, but the Walmart pharmacists were out, one of the first pharmacists that were going out on mobile teams, first pharmacists going to retirement homes and long-term care when that was allowed, huge numbers of vaccines. They worked with first responders, paramedics, fire to get them their boosters ahead of other people, like really, really fantastic work. And I think it helped groups like public health see that there are pharmacists who happen to work in, they often just thought of us as just Shoppers Drug Mart being the most visible, but great pharmacists in independents, great pharmacists in Walmart, great pharmacists in grocery stores. It's changed the idea that you've got amazing professionals in many different environments. And so I think that's why I say I think corporatization is both an enabler and a deterrent in terms of the perspectives for things like public health. Would be interesting to continue this work as we see different approaches in different provinces. Oh, Rita, I would love to keep doing this work. Like I say, it's a 100-page report that we did, really interesting perspectives that really could be expanded elsewhere. Jeff, do you think the perception of the pharmacy within the Ministry of Health has permanently changed? I wonder, Jeff, I hope so. I have worked at a Ministry of Health in BC years and years ago, and there were a lot of pharmacists that were in the ministry when I was there. And I think we do see that here, we have them, but I think at the highest level of leadership, they did start to see pharmacists as people on the front lines carrying out policy, and how, the idea in Ontario where you'd have your executive order that would be released often after the press release, maybe a day, 2-3 days, pharmacists couldn't implement them. Little organization things that they just didn't think of the person on the other end. So I think, yes, and public health, provincially, nationally, and ministries and governments really think highly of pharmacists now. So I hope it's permanent. Jeff, I'm not sure it is, but I hope. Samu, big change in how initial engagement was occurring between regional Ontario health teams and pharmacy, as a few had brought pharmacists to the table. I agree. For Camille, a third-year pharmacy student, heavily involved in vaccine clinics in the GTA last summer, like most of our students. I did a little poll with my students in September, and our class of 120 estimated they had done over 50,000 vaccinations by September. Thanks for sharing all these insightful roles. I didn't know how much went into public health and the pharmacist role. Brad, who's been doing fantastic work. So hats off to you, Brad. Excellent work. Congratulations. It's a perfect example of how pharmacists participate in public health. Like that we mentioned antimicrobial stewardship. He's just wrote a great paper on that that's just out because we've learned a lot from there. And I think that's a huge area for pharmacy to be involved in that. Barb adds she thinks pharmacists across all environments really pulled together. And I think you're absolutely right. And then, so Kate, who designed and created the infographics? So this is an interesting story, actually, and I would love for you guys to all be able to do things like this. So just so you know what goes into it on our end, often we'd create we'd create a Google Doc, and that would be the experts. So the physicians, we were all I was a vaccinator, they were all vaccinators, we were doing thousands, we were talking to patients, they were asking us questions. So we would start to construct a Google Doc with the references and information we needed to use to get our thoughts clear. The science communicators were reading actually way more studies than the health providers were. They had more time for reading the science. We were out there actually doing the vaccine. So they really robustly fact-checked everything, fact-checked every reference, brought new perspectives from rumors online. Once we felt like we got the idea, we had the human factors engineer who would say, oh, don't present numbers like that. Use the same denominator. Research tells us people don't understand if you say it this way. So that was like the content stuff. But the design itself is, I have a graphic designer through Pharmacy 505, and Adrian is a wonder. And so he would put together a draft, and then we would share it on Twitter of just trying to take our most important points and just start to construct them. So a lot of our science communicators, for those of you who just want to do this on your own, would do this through a site called Canva, C-A-N-V-A. I'll put it in the chat after. But you could certainly do this with your team of pharmacists. And then we would always reach out and get feedback maybe from Public Health Ontario or an infectious disease physician or science table, or people that we knew they would catch issues and errors. So a lot went into it on the background. There was a lot of work, a lot of experts, but this is actually something you can do on a much lower level. If you've just got something for your pharmacy, Canva, it's free, and you can make excellent infographics you can share on social media. So I'd encourage you, especially if you speak another language and you want to communicate, there's a real gap there. I think that's a fantastic opportunity.
Thank you so much, Kelly. You got through so many questions and comments in record time. So you make my job easy. Thank you so much, everyone. I hope that this discussion and any other questions you have for Kelly, please use the chat box, or we'll hopefully get to them in the small group sharing circles at the end of today's event. But thank you so much, Kelly, for such a compelling presentation. Perfect for day 4 of the summit. Moving on to our first research presentation of the day, I'm going to call on Simon and Rochelle. Feel free to get your slides up while I introduce you both. Welcome. So Simon Lam is a social worker and a research coordinator at the Factor in Wintosh Faculty of Social Work at the University of Toronto. He also works at the Ontario Association of Social Workers as the interim director, professional development, and the manager for local engagement network program. Rachelle Ashcroft is a social worker and also an assistant professor at the Factor in Wintosh Faculty of Social Work, also at the University of Toronto. She's the first vice president at the Ontario Association of Social Workers and a member of the Transdisciplinary Understanding and Training on Research, Primary Healthcare, which is a national research program striving to build the interprofessional research capacity in primary healthcare. Thank you, Simon and Rochelle. I'll pass it over to you.
Thanks very much, Annalise. I'm so pleased to be here, and it's quite special having 2 social workers coming to spend this time with you. We're pleased to share with you the work that we've been doing this past year, where we've been seeking to understand the impact that the COVID-19 pandemic has had on pharmacists in primary care, specifically as it relates to mental health care. And so we have nothing to disclose and no conflicts. I just want to note that the work that we've been doing and what we're going to be talking about in our presentation has been done with a robust research team. And also just want to note that we have partnered with Dean Dolovich and Annalise Mather. So we do have pharmacists who have been very active in this project as well. And secondly, I just want to note our key knowledge users on the right. They've been really instrumental, as you'll hear, with the dissemination of our survey and for helping us to understand what's going on in terms of the experiences of pharmacists in primary care. And so we know that the COVID-19 pandemic increased demands for mental health care in primary care. And we also know that it changed the delivery of mechanisms of care for Ontario, as well as other places, in terms of the need to shift to virtual technology, such as the use of telephone and video, and some of the asynchronous methods for patient care and for team collaboration. And thinking about that context and all that change that was going on, we wanted to know how the COVID-19 pandemic impacted the role of pharmacists working in primary care pertaining to mental health. And secondly, we want to also understand pharmacists' experiences in the provision of mental health care in relation to the team and how that affected collaboration and teamwork that they experienced during this period of time. So what we did an exploratory study. We did a cross-sectional online provincial-wide survey, and we disseminated this survey to pharmacists working in primary care across Ontario. Our sample population, it was inclusive of all types of primary care models. As you know, in Ontario, we do have such variations in terms of primary care settings and primary care models, but it was inclusive of pharmacists working in family health teams, community health centers, nurse practitioner-led clinics, as well as any other primary care settings. And so we know that between in terms of the numbers that we can get a hold of, we know that between family health teams and community health centers, there's approximately 126 EFTs of pharmacists working in those settings. So there's probably, somewhat more pharmacists, but those are the numbers that we get our hands on. We recruited by sending our online survey to pharmacists by way of our partners through AFTO, through the Alliance for Healthier Communities. We also emailed quite widely using the Ontario Pharmacists Association membership list. So we tried to get it out, and we kept the survey open for quite a long duration between July and October, just to try to capture and get as many pharmacists to respond as possible. We also recognize how busy of a time it was for pharmacists. So we appreciate, anybody who has responded to this, given how busy of a time it has been with the vaccine rollouts and with everything taking place during COVID-19. And so we did leave it open longer for that duration as well. And for analysis, we used descriptive statistics, and our survey was comprised of a combination of open-ended questions and some closed-ended questions. So for the open-ended questions, we did use thematic coding, and the open-ended questions actually provided quite a rich understanding of some of the experiences that pharmacists have been, some of pharmacists' experiences during this period of time. So just to kind of break it down, our survey, we created it as a team. We did do some pilot testing of the survey before we launched it with pharmacists, and we broke it down to 4 different sections. The first section wanted to kind of grasp at what changes pharmacists noted in terms of the mental health needs amongst their patients. The second pertained to specifically what changes or what experiences related to their role in mental health care. And the third section looked at their experiences with their team, and fourth was demographics. And so who did we get to participate? We did have 51 respondents to our survey, and you'll see that in terms of age, we did have representation across a range of different age categories. And in terms of racial background, our sample is largely Caucasian, white. And in terms of gender, our sample is largely female, 76% female. I just want to note that we did give a range of different category options to capture the range of different gender identities, but this is what our sample looked like. So we didn't have anybody who identified as trans or non-binary. In terms of the practice backgrounds, it's really interesting to note that in terms of the time working in primary care, that our sample who did respond to this survey, if you'll see their time working in primary care, more than 6 years. So these are very experienced and people coming with a lot of knowledge and a lot of history of working in primary care, even prior to COVID-19. In terms of the primary care model, the majority of our sample were working in family health teams, but we do have others who were working in community health centers and integrated care teams. And then in terms of just looking at those numbers in the chart on the right, it just illustrates the number of pharmacists working co-located at the same site as the respondent. And so this gives us a sense that there are some of our respondents who were the only pharmacist or working maybe with another pharmacist, but there's also some individuals who responded who were working in sites that would have been much larger with multiple pharmacists. So there's a range of different experiences that may also relate just to the context that people are working in, how long they've been working in it, and just the type of support that they have with their colleagues.
Thank you, Rochelle. So I'll be going over some of the results from the survey. So as Rochelle mentioned, we had some dedicated sections. So the first one I'll talk about is mental health care in relation to patients and also to the participants as well. So for the first question we had was asking a participant, what kind of changes have they seen in the patient's mental health since the beginning of the pandemic? And as you can see, the top three, the vast majority of participants mentioning that patients that they found that patients had worsening mental health, increased anxiety, and also increased social isolation. So none of this is surprising given the impact of the pandemic, but then also some more participants mentioning that if there's increased depression, expressing fear of the unknown, exhaustion, and then also increased substance use, and also increased mental health crises like suicidality. So really having some severe impacts to patients, which really signified the importance of the survey for figuring out pharmacists' roles in supporting patients' mental health. Also looking at sort of what kind of mental health care needs had changed since the pandemic with the patients. So the dark blue here indicating increase in those services, the teal means no change, and then yellow being a decrease. So you can see for the vast majority of our participants mentioning that there's an increase in the need to provide consultations and counseling with patients, specifically around emotional support for patients who are navigating the pandemic, as well as an increased number of referrals to pharmacists during this time, as well as increased number of prescriptions of medications, as well as medication and therapeutic choice review. Not as much for use of medication without prescriptions, but still a pretty decent number of participants mentioning that there's an increase in use of medication without prescriptions. And in terms of the pharmacist's role since March 2020, that there has been substantial changes. We did have a question, a yes/no question, and about 2/3 of the participants mentioning that there has been a change in the role since March 2020. So one of the things that we found in the open and thematic analysis was that there was a change in patient care focusing on urgent issues. And that also meant that it negatively impacted the management of chronic diseases. So recognizing that there's going to be potentially health impact for patients in the future because of focus on urgent issues for patients at this time. Surprisingly, also a shift to virtual care, so in-person being switched to telephone and video services, and then also changing the amount of pharmacy services. The interesting thing here was that there wasn't a clear indication of whether it was increase or decrease. Some people mentioning that there was a decrease in referrals to pharmacies, but then also a number of people also mentioning that there's an increase in referrals to pharmacists as well. There's also more interprofessional collaboration. So with virtual care, having more access to their other healthcare providers on the team. So whether it be on telephone, video, EMR, messaging, and whatnot. We'll also talk more about this later on. And then also an expanded role for pharmacists as well. So as we saw that there's increased demand for consultations and counseling with patients, more supportive counseling, more emotional support, and then also more response to the pandemic. So in terms of what Kelly had mentioned around more support around vaccination clinics, more around supporting those efforts, as well as patient education around vaccines and COVID-19. Along with this, there's also challenges of delivery care with COVID-19. So challenges with providing mental health to patients, and also challenges with virtual care itself as a modality. So a pretty distinct percentage of participants mentioning that there's difficulties in meeting workload demands, and especially virtual care. Some of our participants mentioned that virtual care meant that there was increase in workload because they were able to see more patients because it was virtual, because they could see people back to back. So because of that, there was an increased demand in their workload, and having to meet that was challenging. Also the transition to virtual care was difficult for some of our participants, and being able to switch from in-person to telephone and video overnight, essentially. And then along with that, being able to work with the team in a new way because it was a virtual event, it also means different ways to engage and different ways to communicate. Tied to the workload was around burnout, and then also around changing roles and responsibilities, especially for instance, supporting vaccination efforts. That also meant that additional roles on top of what a pharmacist would be expected to do before the pandemic. With virtual care, especially a lot of our appointments being on telephone, it's hard to read patients' visual cues and body language because that doesn't exist on the telephone. So that was difficult in terms of not being able to read the body language of patients. Also, with technical issues with equipment and software, also internet, the lack of informal conversations with the primary care team, so lack of those hallway conversations, increased workload because of the ability to see more patients potentially with virtual care. And then some lesser ones, some persons also mentioning harder to form that therapeutic relationship with the patients because of the lack of body language on the telephone. And then for some patients not being able to schedule appointments because of technological issues in terms of technological literacy on their end. And also some difficulties in collaborating with primary care teams. So in terms of what has worked well, because it definitely has worked well for a lot of pharmacists and patients around virtual care, is that one of the main things was that participants mentioning that it was increased accessibility for patients. So you can see from the quotes here that for some patients that it was less anxious, there was less anxiety involved in being able to talk to a pharmacist on the phone, on the video, that it was less intimidating, that they felt more comfortable at home, and that they were able to have more forthcoming conversations on the phone or on the video. It's also patient-centered, so in terms of being able to, for patients to be at home so that they could actually pull out a medication in their cabinet at home rather than having to bring everything to the clinic, that they felt more comfortable at home, and that they were able to, pharmacists were able to form that, for some of them be able to form that therapeutic relationship with their patients on a more frequent basis on video and on telephone. It was also able to adapting a wide range of services for virtual care, so in terms of like CBTI groups, alcohol, substance use groups as well. So being able to adapt different modalities, different services onto a virtual platform was very helpful as well. And then also being able to allow for more collaboration with other primary care providers. So as I mentioned before, on telephone, video, messaging, EMR, finding new ways to collaborate with people more easily on the virtual environments. So in terms of collaborating with the primary care team, so 2 ways to look at it. The first one being how pharmacists collaborated during COVID-19. So in terms of virtual care, allowing for increased collaboration with the patient's circle of care, so being able to engage with the physician, with social workers, other people who are providing services, and having those people be available on different EMR services, messaging and whatnot. And that was really able to facilitate a lot more easily virtually. So in this way is also be able to allow new ways to engage with each other, so for instance, being able to provide vaccination information and virtual meetings and town halls at different information sessions that may not have been possible in person because virtually means that they would be able to do that more quickly without having to go in person. So it also means more connecting to different communities and networking and collaborating with different services in the community. So in terms of how other providers contribute to pharmacists in terms of medication management, we had some pharmacists, some participants mentioning that they were able to talk about medication at anxiety and depression workshops. So being able to present in different places, different ways to collaborate with pharmacists, especially not having them to be there in person allows for them to be more accessible in different groups. And then changes in team workflow and also demand for services. So for instance, we saw that physicians, nurse practitioners were also more able to prescribe medication. So that role wasn't just on a pharmacist to prescribe medication. So seeing this sort of shared decision-making within the primary care team. And then lastly, in terms of building capacity for pharmacists in primary care. So the first one in building the pharmacist capacity for mental health care. So we had some participants mentioning ongoing training and education in mental health. So that included access to journal articles, access to formal workshop education around CBT, for instance, and providing the ongoing support for pharmacists to provide mental health care for patients. Also around increased team collaboration. So virtually, how do we ensure that this continues to be a place for people to collaborate online and virtually? For patients, being able to access affordable and effective treatments in the community, so either free mental health care or also being able to access medication at a low cost. And then important as well for pharmacists' well-being, that they are being burned out during this time. So how do we take care of our pharmacists and being able to have pharmacists be confident, be able to address their own well-being as well. And then here, lastly, around building provincial level capacity for mental health care. So at a high level, how do we support pharmacists in primary care? So it also looks at increasing funding for community mental health services. So for instance, being able to provide more services in the community for patients so that pharmacists can refer patients to different mental health services. Also improving medication coverage for patients so that they're more affordable. And also strengthening capacity for team-based primary care. So recognizing that primary care has a key part in responding to pandemics and how to strengthen primary care to be able to respond to those effectively. And then also finding ways to have pharmacists be a key part of that. So whether it be having pharmacists be on an Ontario Health team, whether it be increasing funding for pharmacists in primary care, finding different ways to value and appreciate the role that pharmacists have in supporting mental health care for patients.
And so we have seen in the survey that pharmacists have noted there's high demands for mental health care, and they've been increasingly involved in the delivery of mental health care in these primary care settings. Pharmacists have experienced and endured numerous changes in their role and how care is being delivered over the course of COVID-19 pandemic. And one thing that stood out had to do with the increased need to navigate mental health resources, find funding for medications, provide emotional supports to patients, amongst others. And so as we monitor long-term implications and build capacity to support pharmacists in these settings, it does make me wonder and question, is this the time for us to look at further collaborations between pharmacy and social work, or pharmacy and other mental health professionals? And lastly, it's interesting hearing Kelly talk, because we did hear in our survey that pharmacists highlighted the need to play a role in provincial planning, and building capacity also meant participating in policy and decision making. And thank you. And there's our emails. If you wish, feel free to reach out if you would like to have any further discussion about this. Thank you for having us.
Thanks so much, Michelle and Simon. Absolutely fantastic. And it's, yeah, obviously just very rich data that's come in. And I like the plug for more collaboration between social work and pharmacy. Fantastic presentation. Just in the name of time, I'm going to ask anyone with Q&A to just follow up with Rochelle and Simon directly in the chat box or via email, as Rochelle has shared. But thank you both so much for your presentation.
Thanks, Annalise.
Great. So our next research presentation for today is from RIA GARG. RIA, I'll just ask you to put your slides up when you get a moment. RIA is a fourth-year PharmD student from the University of British Columbia. After graduation, she's hoping to pursue a PhD in pharmacoepidemiology. Her research interests include pharmaceutical policy and health outcomes associated with drug use. RIA, I'll turn it over to you.
Hi, my name's Ria. Can everyone see my slides? They're good?
Yeah.
Okay.
Perfect.
Okay.
Thanks.
Sounds good. Yeah, so my name's Ria, and I'll be presenting my research study, which looked at the impact of COVID-19 on the prevalence of opioid agonist therapy discontinuation in Ontario, Canada, a population-based time series analysis. So first, I would like to start with a land acknowledgement and acknowledge the Indigenous people, the land we're on. And today I'm meeting virtually. And so I do want to acknowledge the ancestral territory of all Inuit, Métis, and First Nations people. I have no affiliations I would like to declare. However, one of the collaborators of this research study was an author of the opioid guidance document that is being evaluated in this presentation. So first, when I begin, I'd like to discuss the intricacies between adherence to opioid agonist therapy and COVID-19. So opioid agonist therapy, specifically methadone or buprenorphine naloxone, as we all know, is a safe and effective treatment for opioid use disorder. However, access, despite it being such an effective treatment, access and adherence to therapy is limited by a combination of factors, including the need for frequent supervised dosing, frequent medical appointments, inequitable access to trained clinicians, and at times patient avoidance of methadone clinics due to perceived stigma. With the onset of the COVID-19 pandemic and declaration of state of emergency on March 17, 2020, these barriers were only further exacerbated as multiple stay-at-home orders were announced, and there was just disruption in healthcare services. To mitigate the impact of these changes on OAT recipients, new guidance for the management of OAT was developed, which included recommendations for increasing access to take-home doses, utilizing telephone or virtual clinical assessments, and reducing the requirement for urine drug screening So overall, the purpose of this guidance was to ensure that OAT recipients could still receive their prescription for methadone or buprenorphine naloxone without having to have in-person virtual or in-person healthcare interactions. So the objective of my study was to investigate the impact of COVID-19 and subsequent changes in OAT guidance on the prevalence of OAT discontinuation. So moving on to the methods utilized for this study. First, to actually examine our objective, we used data that was obtained from and analyzed at ICES. We used the narcotics monitoring system, which captures all prescriptions for controlled substances dispensed from community pharmacies in Ontario, regardless of payer. Then using the registered persons database, we were able to capture demographic characteristics for all people dispensed OAT over the study period. And lastly, hospital admission and emergency department visits were captured using Canadian Institute for Health Information's discharge abstract database and the National Ambulatory Care Reporting System. So the study design used for that we used was a retrospective population-based time series analysis, which looked at Ontario residents who were dispensed either methadone or sublingual buprenorphine naloxone across the study time period, which was April 2nd, 2019 to November 30th, 2020. Specifically, the study period was also divided up into two periods, which included a pre-pandemic period from April 2nd, 2019 to March 16, 2020, and the pandemic time period, which was from March 17, 2020 to November 30th, 2020. For our primary analysis, we actually looked at the weekly percentage of individuals who discontinued OAT. Specifically, we defined discontinuation as a 14-day or more gap between prescription refills. And this, for this analysis, we actually restricted all cohorts to people who were stabilized on OAT, which was defined as greater than 60 days of continuous use. As a secondary analysis, we also compared demographic characteristics and patient outcomes between individuals who discontinued OAT during the pandemic and those who discontinued prior to the pandemic. Sorry. As a sensitivity analysis, we also looked at OAT discontinuation among those who were not yet stable on treatment. So this would include people that were in their initial phases of starting OAT. So this would be people who had used OAT for less than 61 days. And to actually look at the whether COVID-19 and the change in guidance actually led to a statistically significant impact on the prevalence of OAT discontinuation. We used autoregressive integrated moving average models, or ARIMA models for short. So going into our results, so first you can see here we have trends in OAT discontinuation among those previously stable on therapy. I think someone is on hasn't muted themselves. So
yeah, thanks, Ria. I'll just ask everyone to keep on mute during our presentations, and we'll get to questions after. Thanks.
Sorry, to jump back into things. So OAT discontinuation among those stable on therapy ranged between 0.6% and 1.1%, with some variation according to the type of OAT they were on. Specifically, discontinuation of buprenorphine naloxone was generally more frequent than discontinuation of methadone. But as you can see, just based on the graph, the prevalence of OAT discontinuation across the two study periods remained relatively stable. And using our ARIMA models, we ran a step function and a ramp function. So the step function basically looked at any immediate changes, and then the ramp function would look at if there was like any gradual changes to prevalence of OAT discontinuation rates. And we observed that there were no significant step or ramp changes. So OAT discontinuation just stayed relatively stable across the study period. Moving into patient outcomes following an OAT discontinuation, again, patient outcomes did not differ between the pandemic and pre-pandemic time periods. And throughout the study period, 1 in 2 people were actually able to restart OAT therapy within 60 days of continuation. However, one thing I would like to emphasize is that while the prevalence of OAT discontinuation did not change, there was a high burden of all-cause mortality following an OAT discontinuation, as 1 in 100 people did die within 14 days of an OAT discontinuation. Next, we have our sensitivity analysis, which looked at trends in OAT discontinuation among those not yet stable on therapy. And here, the weekly prevalence of OAT discontinuation ranged between 7.3% to 16.6%, with discontinuation for methadone being more frequent than buprenorphine naloxone. Here, again, time series analysis was, the results were pretty consistent with our primary analysis. And as we experienced no significant step or ramp change functions in the change of weekly percentage of Ontarians who discontinued OAT. And again, like as you can see from the graph, other than this one outlier here, the prevalence of OAT discontinuation stayed relatively stable across the study period. So to once again reiterate the findings of the study, the declaration of state of emergency and subsequent change in guidance did not impact the percentage of Ontarians who discontinued OAT, regardless of whether they were stabilized on treatment. We hypothesized that this lack of change was likely due to the rapid dissemination of guidance for the management of OAT early on in the pandemic, which supported continuity of care among OAT recipients. However, while there was no change in patient outcomes or OAT discontinuation rates, I still would like to acknowledge the high burden of all-cause mortality that followed an OAT discontinuation both during and prior to the pandemic. So strengths and limitations of our study. A big strength is that I was able to utilize a large and comprehensive database that captured all individuals in Ontario that were dispensed methadone and buprenorphine naloxone. However, a limitation of our study is that due to the proximity of declaration of state of emergency and the release of new guidance, which happened within the same week, we are unable to disentangle the impacts of those two events individually. We were also unable to access dispensing records for individuals in correctional facilities or those administered treatment in hospital. Lastly, there were other barriers to OAT adherence that we did not examine, which include race, immigration status, and housing status. So implications and future directions. So once again, to reiterate, continuous use of OAT definitely has been shown to reduce the risk of opioid overdose and mortality. While we found that the COVID-19 pandemic and change in guidance did not impact the prevalence of OAT discontinuation in Ontario, there was still a high burden of all-cause mortality that occurred following an OAT discontinuation. So this really reinforces the need for expansion of harm reduction services and low barrier access to OAT to support treatment retention and really to also support people if they choose to taper off of OAT therapy, or if there's an abrupt discontinuation in OAT therapy. And this can include safer spaces to use drugs, increased access to naloxone, and recovery support services that are there to support patients either when they're starting OAT or when they discontinue therapy. So to end my presentation, I'd like to say thank you to all the funders and data providers that made this study possible. Thank you.
Fantastic. Thank you so much, Ria. This is a fantastic piece of research, given your background. And yeah, hopefully this will carry forward into your PhD. I hope that truly works out for you. I'm just going to encourage people to follow up with Ria in the chat as well, just in the name of time for today. I think if you can ask any questions in the chat box or save them for the small group breakout sessions, we'll hopefully get to some of the Q&A there. But thank you so much.
Thank you.
I'd just like to introduce our next two presenters, so Shelley and Maddie. If you could get your slides up, I'll just introduce the two of you. Madison Fullerton is the Director of Research and Community Engagement at 19 to 0, where she leads the execution of primary research initiatives through mixed methods design. She holds a Master's of Science in Exercise and Health Physiology from the University of Calgary and has since specialized in behavior change research through community at a grassroots level. Dr. Shelita Dattani is the Vice President of Pharmacy Affairs at the Neighborhood Pharmacy Association of Canada, and in this role, she leads a team advocating for pharmacy's evidence-based role in delivering accessible, high-quality healthcare and building capacity in public health and primary care. Shelley is a pharmacist with over 20 years experience in many sectors of the profession, including community, hospital, academia, industry, group purchasing organizations, and professional and pharmacy associations. I'll let you two take it from here.
Thanks, Annalise. I'm going to start us off. Can everybody hear me okay? Maybe Maddie, if you can give me a thumbs up if you can hear me, that would be great. I've had volume issues, so thank goodness. Okay. Well, thank you, first of all, for we're following some great presentations and a fantastic plenary by Kelly, and I'm so happy to see this theme because it's something that I think a lot of us are passionate about, and clearly a lot of people outside pharmacy now see a really big role for pharmacy to be important partners and bridge builders with public health. So I'll just, we kind of made friends with 19 to 0 serendipitously about shortly after I actually started at Neighborhood Pharmacies, invited to one of the co-founders onto a webinar very early in the COVID immunization stage and talked and realized we had some mutual goals around pharmacy having a greater role in immunization beyond flu and COVID. So out of that came some brainstorming ideas, and we decided to do some work to look at what's really happening in the routine immunization space. Thanks, Matt. You can go to the next slide now. So this is just our disclosures. You can see mine and Maddie's disclosures there. We have also listed here for the organizations that we have relationships with that we don't believe that there are any conflicts and how we mitigate the bias. If you want to go ahead to the next slide, Maddie, thanks. So, I don't think anyone in the room would disagree that routine immunizations are the single most important innovation in public health. They play a very critical role in limiting vaccine preventable illness. We've learned so much about the value of this and gone through trust and mistrust and all the things that Kelly talked about with people believing in vaccines or not believing in vaccines or having discussions around vaccine hesitancy, but we know how important immunizations are, and routine immunizations play a really important role. But despite that, we know that even before the pandemic, the uptake of routine immunizations, like things like shingles and HPV and pneumococcus, were still well below the NACI recommended targets. And if any of you are familiar with the CanAge report that looks at, sort of does a report card of older Canadians across the country, province by province, and looks at a number of things like NACI targets and access to vaccines. And basically most provinces aren't being graded very well in terms of where we are in terms of getting older Canadians their vaccines. We know that routine immunizations are still primarily administered in primary care or public health settings. We've in pharmacy have been giving flu shots for a decade and a half now across different provinces, and now we have been a major player in giving COVID immunizations. But with respect to other routine immunizations, they're still administered predominantly in other channels. It's not a scope issue. Pharmacists generally across most provinces actually have the scope to actually administer vaccinations, and now most routine vaccinations don't even require prescription technically, they're Schedule II. But despite that, there are other barriers that limit the ability of Canadians to be able to access routine immunizations, whether it's accessing publicly funded vaccines in pharmacy, whether it's not able to access them through wholesale distribution, whether it's a scope issue, for example, for pharmacy technicians who now in many provinces can give both flu and COVID vaccines, but not routine immunizations, or whether it's remuneration, which is still an important incentive to getting people vaccinated. We know also that primary care provider access, and Kelly talked about this, has been really limited during the pandemic. I mean, providers have been practicing virtually. A lot of them are back face-to-face. I work part-time in a primary care environment myself, and I know how much we rely on community pharmacists to help out. But there are still, there are going to be, and there are still additional challenges to accessing routine immunizations, and we certainly speculate that it's a challenge. So we wanted to really understand from the public, is this really a challenge? Are you caught up with your routine immunizations? What are the challenges? And then further, we wanted to understand a little bit more about the role of pharmacy. And we feel that pharmacy is a great place to get immunized, but what does the public feel? So I'll turn it over now to Maddie, and she'll take you through sort of the beginning of some of our work.
Awesome. Thanks, Shelley. Yeah, so just to reiterate kind of the objectives for the work that we did. So using self-reported data, there was two things we wanted to do. The first was to evaluate the number of Canadians who received routine immunization during the COVID-19 pandemic. And the second was to evaluate public perceptions towards pharmacy as a way to administer routine vaccinations. So what we did is, in collaboration with our partners at the University of Toronto, we launched a survey online in both English and French. This was from late summer to early fall of 2021, and we had just over 9,000 respondents, so quite a large survey. Participants were recruited from Dynata and Abacus, and we used a rank weighing algorithm to weigh different categories of respondents to represent Canadians. So in particular, things we wanted to target were gender, age, language, and region. Just to keep moving us along, so based on the respondents that we had, the gray circles represent the number of respondents per region. So obviously the N that we had in each province differed based on the Canadian population. Overall, we had equal representation from males and females, as well as an equal number of respondents from the ages of 25 to 65 plus. So a very, very diverse sample that we were hoping to be reflective of the Canadian population. We have a lot of results that we want to share with everyone, so we're going to jump right into it. In particular, I'm going to speak to the routine immunization coverage rates that we explored. So the figure here represents respondents' answers to the question, are you up to date with, say, for example, your tetanus immunization? So the first main result we really want to highlight is that based on self-reported data we collected, routine immunization rates are well below NACI's targets of 80% for tetanus, shingles, and pneumococcal. I would also like to note, similar to what Shelley said in the background, that these trends are similar to what they were pre-pandemic. We also found that region to region, so comparing the West to Ontario to Quebec and the Atlantic provinces, that each region is on par for tetanus and pneumococcal vaccines. All right, so when looking at willingness to vaccinate, the next, insight we would like to highlight is that people want to be immunized, period. When we ask the question, would you be willing to, for example, get your tetanus immunization in the next year? Over 40% of those needing a routine vaccine are willing to be immunized, and that's shown here on the figure in the green. Of those who are not immunized, approximately a quarter of respondents are unwilling to become up to date on their immunizations, and a third of respondents who are not up to date are unsure about receiving them. And again, that's shown here in the figure in the pink and the blue. This data here on this slide particularly suggests that there might be opportunities for healthcare providers to assist in vaccine education. Okay, so when we look at whether or not respondents or their children have missed or delayed a routine immunization due to the COVID-19 pandemic, we found that 13% of adults and 23% of children have reported missing or delaying a routine immunization. So this suggests that over 5.3 million Canadians have missed or delayed a routine immunization since the beginning of COVID-19. It is important to note on this slide that this is self-reported data, and so it is likely that these numbers are underestimated, as a lot of individuals may not remember when they were due for their next round of immunizations, which is quite common. So when digging into the reasons for why respondents missed or delayed a routine immunization, we found that approximately half of adult respondents identified reasons related directly to access issues. So this includes 26% of people not wanting to visit a family doctor or a public health office during the pandemic, as well as 23% not being able to make an appointment with their family doctor. So other access issues that we identified here in this graph include not knowing if routine immunizations were even being administered during the pandemic, as well as people just simply not knowing which vaccines they were due for. So ultimately, approximately 7 in 10 individuals missed or delayed adult immunizations, and we believe this easily could have been avoided with improved access to healthcare providers. So similarly on the next slide, so this is specifically looking at the same set of questions that we just showed on the other side, but for children. So when asking parents why their child missed or delayed routine immunization, we found that 69% of respondents indicated reasons, again, related directly to access issues. So those were the same main issues that were reported on the previous slide. In addition to these provider access barriers, school-based cancellations were responsible for about a quarter of these missed vaccines during the pandemic. And then one last piece to note is that overall, provider access seems to have impacted children more than adults when looking at these last two slides. But we also found, which is interesting, that unwillingness to vaccinate was much lower amongst children than the adults that were surveyed in our survey. And now I will hand it back over to Shelley to go through objective 2.
Thanks, Maddie. That was a great job. That 70% of vaccines could have been avoided by improved provider access just floors me. I mean, we know that we're all and have been very busy, but the amount of catch up we're thinking about now and what we could have potentially, even before the pandemic, given to people with improved provider access is just amazing. So, the second half of this is really around what do Canadians value? Again, as I said at the outset, we know that we believe that pharmacy is a great opportunity to get your all of your public health needs, many of your vaccination needs, but do Canadians feel the same way? So we asked about a number of factors, and we said, basically on a Likert scale, how important are various things to you when it comes to getting your vaccine or your child's vaccine? And you can see those sort of listed on the right-hand side of this slide. But the big insights that we found here were that people value flexibility, they value community-based options to get their routine immunizations. And so this suggests that, the destinations that are right in your own communities are valuable to people like pharmacies. They value proximity to the vaccination site if they're able to walk there, easily get there, potentially even have the vaccine come to you. Access means different things to different people. That was the most important thing to Canadians, that was proximity. Receiving a vaccine at the recommended age was important as well. We found that it was particularly important to older Canadians who were afraid of some of the more vulnerable illnesses, whether it's pneumonia or shingles or other things that could be avoided with vaccines. And maybe we'll go to the next slide, Maddie. And then we found that, about 70% of Canadians said we favor having more options to get vaccines at our community pharmacy. When we asked them that, 70% of them said, yes, we would like to have more options to get things outside of flu and other vaccines at the community pharmacy. And that was fairly consistent across all of the jurisdictions across the country. We didn't really see any differences there. And then, you know, we always talk about trust with pharmacists, and we have several polls and surveys that many of our stakeholders and associations have done, talking about how much people trust their pharmacists. But we wanted to understand, do you actually trust your pharmacist with your vaccine record? If your pharmacist had access to your vaccine record, if potentially they could even input into your vaccine record, would you be okay with that? Because that's an important enabler to care as well. And certainly Canadians did say we feel very comfortable with pharmacists accessing our vaccine records. Said that almost 80% of them said that. And also they felt comfortable with pharmacists then recommending routine vaccinations based on those records. As Maddie alluded to earlier, there's a great population of people that are just unsure. If you ask me right now, when my 16-year-old got her last tetanus shot, I could not tell you. Hopefully I'd be able to go and look on my app or at the yellow card somewhere, but there's a lot of people that are unsure. So being able to have that access in a pharmacy touch point is important and something that Canadians are comfortable with. And then of course, you know, just the touch points, right? We often talk about the fact that people interact with their pharmacist 7 to 10 times more than they do with their family doctor. And certainly during the pandemic, because of open doors and access, pharmacists became a routine sort of destination for healthcare questions. So that high frequency of touch points and the ability to have that face-to-face contact is another potential opportunity to increase vaccine uptake. So every interaction is an opportunity potentially for a discussion about immunization. And then if we go to the next slide, we also, this was really, really interesting to me. I really thought this was a very salient point, is that, you know, 56% of Canadians said, if I was in the pharmacy for another reason, I was picking up toilet paper, or I was picking up my amlodipine prescription, or I was picking up an antibiotic, if a pharmacist actually recommended, or a pharmacy team member recommended a vaccine to me on the spot, I would take it. And we know how valuable that can be with some of the vaccine hesitancy literature that's out there. So the fact that, you know, there's no real other place in the healthcare system that I can think of where you can potentially walk in for another incidental reason, be offered a vaccine and get it right there. So that the impact of that is, I think, phenomenal and something to think about. And so that was really interesting to us, that most Canadians were willing to take a sort of an unplanned routine vaccination. They aren't thinking about it. They have a discussion about shingles. They have a discussion about pneumonia, HPV, whatever it is, and they would take it if offered by their pharmacist. And then, you know, we also, you know, learned that many Canadians just rely on their healthcare provider to recommend those routine vaccinations. And so as Maddie presented earlier, there are opportunities to proactively have those discussions with patients that you know, pharmacy professionals need to continue to take. Again, appreciating how burnt out and acknowledging, you know, all of the stress on pharmacy right now. They are well-suited destinations, though, to offer those unplanned immunizations. So, I mean, I think in summary, you know, as Maddie shared and I shared with you, even prior to the pandemic, we're still challenged with routine immunization rates. The second CanAge report that just came out a few months ago in 2022 showed us that we are still not meeting targets across provinces for older Canadians and their immunizations, and those folks that are even more vulnerable to vaccine preventable illness. We know that almost 70% of missed or delayed immunizations could be improved with improved provider access. Again, a really impactful point, I think. And not a surprise to us, but something that is good to hear reflected back to us from 9,000 Canadians is, yes, we do value flexibility. We value accessibility, which isn't always the same thing as convenience. We also do value convenience and the proximity that a neighborhood pharmacy can offer us. And that this was fairly consistent coast to coast, in that Canadians from BC to Newfoundland wanted more options and were open to more options to get routine vaccinations at their local pharmacy. And then the trust piece. So if pharmacy had actual access to a vaccination record, which is a real barrier right now, they would be able to, they would be open to taking that vaccine right away. So that is it for us. I'm not sure, Annalise, if we have time for questions or if we want to just.
Yeah, thanks. Thank you so much, Shelley and Madison. Fantastic piece of work, and yeah, hugely representative, I think, just tonight to have such a nice sample across Canada. In the name of time, I'm going to push us to our fourth research presentation, but I'm hoping in the small groups, be able to have more time for Q&A. And I think if you want to respond, I think Suzanne has a question maybe in the chat that you can go back and forth with. So with that being said, I would like to introduce SAMEERA. I'll ask you to put your slides up on the screen whenever you're ready. Dr. SAMEERA TOENJES is a pharmacist currently pursuing a Master of Science in Pharmaceutical Sciences at the University of Toronto with Dr. Lisa McCarthy. She enhances patient care through her role with the RIA Prescribing research team and clinical practice at Women's College Hospital, just across the street from where we are now. For her Master of Science thesis, Dr. TOENJES is applying qualitative research methods to better understand how to address prescribing cascades, an important and under-recognized contributor to polypharmacy. Thanks, SAMEERA.
Awesome. Thank you, Annalise, for the introduction, and hi, everybody. As mentioned, I'm SAMEERA, and I'm doing my master's with Lisa McCarthy here, who I think is also helping to facilitate this session. So today we've had some great presentations on how COVID has really strengthened the links between community pharmacy and public health. My project is taking us down a little bit of a different path, focusing on something called prescribing cascades, which is another public health problem. And specifically, I'm going to talk about my project, which is on developing a practice guidance tool for prescribing cascades in primary care. And so today I'll really be discussing the objectives and the layout of my project. I have no conflicts of interest to disclose. Expenses for my research are supported through a grant from the University of Toronto, and they don't have any influence on my data collection or analysis. So to start off, we can start by defining prescribing cascades. So for anyone unfamiliar with the term, a prescribing cascade occurs when an initial drug therapy is prescribed. It causes an adverse drug event to occur, and then a new drug therapy is prescribed to treat that adverse drug event. And so why do they happen? And many times this is because that adverse drug event in the middle is misinterpreted as a new medical condition. And so this misinterpretation is also more likely to happen when there's an extended time frame between that initial drug being prescribed and the resulting adverse event. And so why are cascades a public health problem? So they are really an underexplored cause of medication-related harm. So we have some forthcoming evidence linking particular cascades to an increased risk of emergency department visits or hospitalizations. We also have some data coming out of America showing that specific cascades have impacts on quality of life. So they found that this specific cascade was associated with a statistically and clinically significant decline in physical functioning. And then we also know, by virtue of adding more medications to a person's medication list, cascades are contributors to polypharmacy, which is associated with things like increased risks of functional and cognitive decline, falls and fractures, and other bad outcomes. So to address this, the research team I've been a part of has been studying prescribing cascades for the past 4 years. And broadly, the goals of the team are first to enhance the understanding of how and why prescribing cascades happen. And second, to identify opportunities for intervention at the individual practice and healthcare system levels. So to do this, the team has kind of conducted a series of interviews, the results of which were used to guide a behavioral analysis to reach those objectives. And that analysis resulted in a number of intervention options for addressing prescribing cascades in practice. And so my part in this project is really to gather the stakeholder input on the prioritized intervention to really inform its future design and implementation. So I'll just do a quick overview of what we learned from the interviews and really the complexity and maybe muddiness of prescribing cascades. So interviews were done with patients, caregivers, and clinicians across different settings. So that includes a geriatric day hospital, long-term care homes, and primary care. And so they found a few interesting things. So first, they found that clinicians and patients both have troubles recognizing prescribing cascades in practice. And this is often because people don't think about medication side effects and may be unfamiliar with the concept of prescribing cascades themselves. Second, they found that even when people are familiar, sometimes there's a lack of information to sort out if it's a cascade. So potential barriers include conflicting reports for the indications of medications, or also difficulties understanding the chronology or timeline of medications. Third, we heard that there's kind of varying feelings of accountability if a prescribing cascade is found in terms of who takes on that role in sorting it out. And finally, even when people suspect a cascade and are interested in tackling it, they struggle to know what to do. And this is often related to a lack of information about the risks and the benefits of the cascade. So essentially what these findings mean is that there was a need for guidance in practice to support the identification and management of prescribing cascades. So in terms of the behavioral analysis, our team used the behavior change wheel, which is pictured here on the left. It's a model that looks to understand three components that underlie behavior. So capability, opportunity, and motivation in order to accomplish behavior change. So through this analysis, 6 different behaviors involving the public and clinicians were identified as targets to improve the identification and management of prescribing cascades. And then internally, the team did a prioritization process and decided to focus the next step for intervention development on ways to help clinicians help them recognize, investigate, and manage prescribing cascades. And when we looked at this behavior, we found that key drivers were capability and opportunity. And that led us to broad categories of intervention types such as education, training, and environmental restructuring. And then as we continue to kind of work through this process, we came up with 6 interventions that were really prioritized for consideration. But when we tried to narrow down the options further, we realized that the foundation really underpinning all 6 of those intervention ideas was a practice guidance tool. And so what's a practice guidance tool? It's something that provides an organized and systematically developed statements to help clinicians make decisions about how to best care for a patient. So this could be thought of as something like a good practice guideline, maybe a thought process or algorithm. And then once we have that practice guidance tool, we could then use the intervention ideas to help kind of bring this tool to practice. So ideas like an education program or a QI collaborative. So now we're here really at this junction where we wanted to gather more clinician feedback to understand the important features of the tool. So we're in the middle of focus groups and data collection right now, really, but here's what we're working on. So we recruited clinicians from Ontario's interprofessional primary care teams, and that included physicians, nurse practitioners, and pharmacists. And so we conducted a series of focus groups. So first they were intra-professional focus groups, followed by inter-professional focus groups. And the goals of the first set of focus groups were to first explore the barriers and facilitators to tackling prescribing cascades in their primary care teams, and then to identify important features of this practice guidance tool. And then in the second set of focus groups, where we brought together the individual professions, we are now looking to gather more feedback on the next steps for creating this tool. So we did use 2 frameworks to kind of guide our discussion. First was the theoretical domains framework. And as mentioned before, we were discussing the behavior change wheel and how behavior is really driven by capability, opportunity, and motivation. So what the theoretical domains framework does is it kind of provides a more nuanced way to understanding the contributors to those drivers. So this slide kind of shows one way at looking at how these 2 frameworks can link. So if we look at an individual or group's capability, this can kind of be understood by looking at their knowledge, their skills, their memory, attention, and decision processes, etc. We also use the Guide M model which was something created to help guideline developers increase the implementability or uptake in practice of clinical practice guidelines. And so we use this to guide our questions about what they see as important features of this tool. So we ask questions largely around creating the content. So what would they like to see in a practice guidance tool for prescribing Cascades? And how would they like this tool to work? For the planned analysis, we're planning to do reflexive thematic analysis to identify themes and patterns in the transcript using the theoretical domains framework and the GuideM model kind of as sensitizing frameworks for the codes. And more details are on this slide here, but I won't read through it for the sake of time. I will say that right now we're kind of in the midst of these focus groups and we're pretty excited to come back hopefully in a few months and tell you what we've found. In terms of implications, so about our project, so by shaping primary care clinicians' prescribing behaviors by helping them tackle prescribing cascades, broadly our research aims to reduce medication-related harm. So at a patient and clinician level, this can help to address inappropriate prescribing and possibly reduce the risk for medication-related adverse events. And then for the health system, this may reduce unnecessary costs. So in summary, prescribing cascades are important and under-recognized contributors to medication-related harm. The development of a practice guidance tool with clinician feedback is really our next step in helping clinicians recognize, investigate, and manage prescribing cascades in practice. And I'd like to acknowledge the team I work with for all their valuable contributions to this project. So notably Doctors Lisa McCarthy, Leanne Jeffs, Sarah Gilcher, Barbara Farrell, and Colleen Matej for all of their help and wisdom that they've brought to this. And now I will stop sharing. And oh, I think my contact information was also on that slide, but I can type it in the chat if anybody has any questions.
Thanks, SAMEERA. That sounds great. I think just given that we have about 10 minutes before we'll wrap up today, in place of the small group sharing circles, I think I will just ask for an open Q&A session right now. So if anyone has a question for one of our presenters, for Kelly, or just a general comment, please just use the raise hand function, and then I will ask you to unmute and we'll go from there. And if people want to turn on their videos, we can do that too, and see some familiar faces, hopefully, and whatnot. Jeff, yeah, I'll turn it over to you.
I don't know if RIA is still on the line, but I was intrigued with her presentation on OAT, and in particular that there was no change in discontinuations, but I believe there's also recent studies showing that the use of take-home medication in OAT did increase quite a bit. And I wonder if she's connected those two things, or is somebody connecting those two things, because it seems to me that the take-home medications went up, but then went back to where it was. And so I'm curious as to what's going on there and what it says about OAT therapy and how it was managed in the past versus how it was managed in the pandemic.
Thanks, Jeff. I don't think RIA is still with us online, so I'll just open it up to our audience. Hi, everyone. Can see some faces now. If anyone else has comments on that or more insight.
I guess I can comment on that for a moment.
Yeah.
Hi, Jeff. Yeah, I think we still have to figure out the various pieces of research that's coming out from this, because the ODPRN work is great, and it's kind of showing different aspects of the potential or the increase in carries over the pandemic. And that is the big question, what should happen going forward? And I think some of the questions that are still out there is because their work has focused on one part of the pandemic, it'll be good to see kind of with longer term data, what's actually happening. And two, you know, the person that presented, her name escapes me now, but at one of the previous summits, one of these open summits, was looking at like just the actual percentage of people who had changes in their carry levels, and it was fairly small. So I think kind of interpreting, you know, what happened over the pandemic and the attribution to the change in carry levels is something we still need to figure out a little bit more.
I hope someone will put those things together, because I think it's really fascinating and a great opportunity to change clinical practice based on some real data.
Absolutely. That it is the biggest question we have at the moment, I think. In general, though, it's that the approach now is to at least be more flexible. I think the next step is going to be to see working with patients individually to see which ones would benefit from a bigger more carries, and those that would benefit from more support, because everybody's different and some do better with one or the other. And so figuring out how that comes into practice is one of the big challenges. Also, it's a lot of clinical judgment and working directly with patients in their goals.
Thanks, Beth. Thanks, Jeff. Those are both great comments. Shelley, I know you put in a bit of a comment in the chat box. Not sure if you want to elaborate on that.
Sure, why not? I think there was some good discussion, actually. You guys can hear me, right? I don't. Sorry, just computer challenges. Around, you know, I don't want to be tone deaf to the fact that, you know, we have a lot of burnout in the profession right now. And I want to acknowledge that because a couple of people said some things in the chat. And so I was just sort of acknowledging that. And I think while we say we want to do more, we also want to be mindful that we need to protect the profession and the sector in order to be able to safely provide care to Ontarians and Canadians. And so in our advocacy work, we have those conversations, and we talk about how things like, you know, whether it's reducing administrative burden in pharmacy, whether it's improving funding so that we can have better staffing, whether it's things like, this actually came right out of our advocacy in Ontario. For example, I think Kelly mentioned it earlier, advocating for if pharmacy operators want to hire nurses to give COVID vaccines in their pharmacy to build bandwidth to permit them to do that. And that was something that we did successfully in COVID. So I just want to acknowledge that it is a time in our profession and sector where we're all very burnt out and exhausted, and we don't want to minimize that that's a real thing, but we still know that there's capacity building that can happen with support, the appropriate supports in pharmacy with patient safety concerns as well.
I think that's actually a great place to kind of wrap for today, wanting to be respectful of our 3 p.m. Timeline to end. So Annalise, to close, wanted to just remind everyone and to thank everyone. So this program was brought to you jointly by the Ontario Pharmacy Evidence Network, as well as the Centre for Practice Excellence at the University of Toronto. I think Annalise is trying to get our contact information up, maybe with not much success, and that's okay. If anyone is not aware or subscribed to our newsletters or our social media accounts, then we can circulate that information. Please join us. To me, I'm always excited by our chances to have like virtual reconnection and learning from each other. And across this summit series, I've been energized by the range of topics that we've been able to cover as a result of your active involvement. So today alone, if you think about it, right, we visited mental health, opioid agonist therapy, immunization routinely, and prescribing cascades that is contributors to medication overload. So to me, a common thread of that has been to showcase the role for pharmacists and pharmacy teams and how we're poised to positively impact Canadians' health. The bridges built with public health in the last few years are really, to me, realizing something we've discussed for a long time about pharmacies as health hubs, and I really feel like we're just beginning. And it speaks to the power of disruption as an opportunity for innovation. So on behalf of the Open Executive, so that's myself, Sherilyn Houle, Nancy Waite, and Lisa Dolovich, and Zuan Austin and Annalise Mathers from the Center for Practice Excellence, we have many people to thank. So our speakers, our scientists, our stakeholder, and our public advisory panels, and all of you for your active involvement in being here today. On a special note, I'd like to take a moment to recognize the tremendous amount of organization and coordination that's needed to realize this summit series. And so a special shout out and thank you to Annalise Mathers for all of her effort. She really keeps us going and organized. Please, for all of her work to bring this together for us over the last few months. So I love the love and the clothing. Annalise, we'd be lost without you. In closing then, at 3 o'clock, I want to wish everyone good health, and picking up on the thread that Shelley said, time to recharge with your nearest and dearest this summer. So thanks again, and we look forward to seeing you soon.